Good morning, esteemed chairpersons, colleagues, and friends. It's an honor to stand before you today, not just as a surgeon, but as a fellow traveler on this long, unpredictable, and deeply humbling road we call surgical practice. Over the last 4.5 decades, I have gathered not just skills and knowledge, but some insights, some hard earned, some silently acquired by experience. Today, I was asked to share a few of those learnings with you. I'll try and do that in the next 15 minutes without attempting to sermonize. But before I do that, I must pay my respects to the institutions and the mentors that groomed me. I was blessed by being in the right place at the right time. To start with, two great institutions, JIPMA Pondicherry in 1975, where I graduated from, and PGI Chandigarh till 1981, which changed the course of my academic outlook and life itself. The department in PGI was more than a surgical department. All these were my teachers and heroes. Professor B.L. Talwar in the middle, Doctors Bose, S.K. Khanna, N.M. Gupta, S.P. Kaushik, J.D. Vig, Kuldeep Singh, and R.V.S. Yadav. I am forever indebted to them. This was a picture in 1980, just as I was leaving. Nizam's Institute of Medical Sciences, Hyderabad, is where I began my career nearly 40 years back and served till my retirement 12 years ago. During my more than 25 years at this institution and later at KIMS, Secunderabad, for the past 13 years, I contributed my bit to the training of many of the current outstanding GI and HPB surgeons. The first thing that I learned is that surgery does not stand still. Techniques evolve, technologies shift. What was gold standard yesterday becomes obsolete tomorrow. Conferences, journals, workshops, they are not indulgences, they are lifelines. I have learned that staying current is not optional, it's survival. Remember what the Red Queen said, you have to keep running just to stay in place. Very true for surgical learning. If you stop running, you will lag behind. The second learning is over time I've come to trust my clinical intuition or clinical judgment, which basically uses a broad synthesis of patient history, examination, leading to a pattern recognition and a tacit expert knowledge that is not easily encoded into a test or a prediction rule. And this type of clinical judgment can indeed outperform diagnostic tests that have low predictive value, especially in complex or ambiguous cases. I'll show you how a weak test, a test of low yield, particularly in uncommon conditions, can lead us into a statistical trap. If a disease affects 1 in 1000 and a test has 95% specificity, which means 5 out of 100 or 50 people out of 1000 will test positive falsely, while only one is a true positive. That is a 98% chance that the result is wrong. And false positives can cause real harm. Unnecessary interventions, overdiagnosis of indolent cancers, overtreatment with lifelong consequences, and the resultant psychological distress. That is where context matters, probability matters, and this is where selection of a test or an intervention matters, supported by clinical intuition. Surgical excellence, I have realized, is shaped not just by evidence. Beyond the evidence, there is the experience and the intuition developed over decades. The lessons that are not necessarily published in journals but etched into memory. And today, standing here, with whatever surgical foundations, I am reminded that surgical excellence does not rest solely on what we do. It results on when we do it, why we do it, and whether we are doing any harm by doing it. Normal cases teach us rules. We all know that there are no laws of medicine, which is quite an uncertain science. Outliers are the rule. But what I have learned is that outliers are equally, if not more important than normal. I am always reminded of this 30-year-old lady with gallbladder cancer who is still living 25 years after a right trisectionectomy. Or this 55-year-old with again a right trisectionectomy for metastatic neuroendocrine tumor of the liver, who 8 years later presented with lesions in ileocecal region and pancreas, and after 2 years of central pancreatectomy and ileocecal resection developed widespread dissemination into the peritoneal cavity, lungs, spine, and liver, and 13 years after she developed dissemination is still asymptomatic. PRRT has not made a difference. And now she says she and the tumor have developed a friendly symbiotic relation. She refuses any further treatment, saying they have learned to live together. These are exceptional responders. There is this study on the so-called exceptional responders with significant findings at molecular level, suggesting what makes them exceptional, making Siddhartha Mukherjee in his popular TED talk and book on the laws of medicine emphasize that normal cases teach us rules, but it's the outliers that teach us laws. It is when you delve into these exceptional responders that you are reminded of the popular quotation attributed to Voltaire. Doctors are men who prescribe medicines of which they know little, to cure diseases of which they know less, and in human beings of whom they know nothing. A little nihilistic, but it does help in grounding us at times. We must learn to make decisions in the face of uncertainty and honor the exceptions. Surgery demands more than skill. It also demands a stillness. A pause before a major decision saved me from disaster more than once. Planning, precision, pause, and patience. I repeat, planning, precision, pause, and patience. They are not just virtues, they are survival tools. During a timeout in surgery, we should reorient ourselves and take stock of the situation. Get out of the conformational bias. You know, the tendency to see what we expect rather than what is actually there. Double check for any missing or abnormal anatomical landmarks. Ensure that all team members are on the same page. Encourage open communication. Anyone can speak up if they notice something unusual. It's not just about technical skill, but about cultivating mindfulness and humility in the operating room. Again, remember, taking a moment to pause can prevent irreversible mistakes. No surgery is solo. Success is built on trust, not just between surgeon, anesthetist, nurse, and technician, but your peers in other domains, endoscopists, interventionalists, imagiologists, and oncologists. Respect and communication are the invisible sutures that hold the team together. And a multidisciplinary approach intuitively works better as long as it does not become a multidisciplinary conflict. What I've also learned is beyond the knife, patients need clarity, reassurance, and presence. Explaining the procedures, listening to fears, and simply being there These are as healing as any incision. Mistakes are inevitable. What matters is reflection, owning the error, understanding it, and ensuring that it does not happen again. I can never forget the first Whipple I witnessed during the period when there was no imaging and a pancreatic head mass was diagnosed by clinical judgment and is what is called a hypotonic duodenography, a variant of barium meal. And after 8 hours of painstaking brilliance of meticulous surgery, when the specimen came out and I eagerly received it outside, to everyone's horror, there was no tumor. It was a large calculus at the lower end, a never event. But how the surgeon owned the error, called a meeting of the team, stopped surgeries for the next few days, did bedside monitoring himself, the senior most in the unit, till the patient recovered, was a great lesson. Long hours and high stakes of our profession do take a heavy toll of us emotionally. Stresses and challenges are common. What is required is resilience. And resilience is not just mental, it is physical, it is spiritual, it is communal. Resilience is what keeps us going when everything else says stop. Ethical dilemmas are part of the job, but integrity must be non negotiable. The patient's well being must always come first, even when it is inconvenient, even when it is costly. Teaching young surgeons has been one of the most fulfilling parts of my career. Mentorship is not just about passing on knowledge, it's about passing on values, humility, and hope. A student once asked me, on Teacher's Day, no less, "Sir, did you ever regret becoming a surgeon?" I paused and I thought, yes, I have regretted it. While hunting for residency, watching non medical friends glide into smooth jobs, during residency, when sleep deprivation felt like torture, later, when others were raising families, I was still trying to find my footing. And every time a patient died unexpectedly when I thought I had done my best, and every time a patient inexplicably responded with complaint and contempt instead of gratitude. And yet, I also had moments that made it all worth it. A beaming face sends me a message 20 years after Whipples for pancreatic cancer. A young man insists on seeing me because his grandfather, saved 30 years ago from deathbed, told him, go only to Dr. Shastri. In those moments, I felt the invisible thread of trust, legacy, and healing. I realized I did make a difference. I was appreciated, sometimes even idolized. No, now I have no regrets. We cannot forget how a stable family helps us maintain a healthy work life balance. An understanding spouse who is ready to support you, ready to catch you when you have a fall, and provide a safety net for taking more risks, does not hesitate to ground you to earth during the times you are on cloud nine, during high moments of success, and provides useful tips and offers a helping hand in editing the narrative of your talk. Thankfully, I have one. And with children as pillars of strength is a secret behind many a successful surgeon. Sometimes I also think, what I wish I had done more. If I could go back, I would develop more hobbies to take care of my free time now, spend more time with family, publish more, but I wouldn't change the path because this journey, this surgical life has shaped me in ways no other could. Finally, to the young trainees in this hall, your future will not be defined by the number of procedures you perform, but by the number of unnecessary ones you avoid. Learn the algorithms, but question them. We are still evolving. Know the guidelines, but learn to pause when they don't fit the patient in front of you. And to my peers, let us not teach the techniques, but the temperament, the ability to pause, to own and learn from our mistakes, to collaborate, and to ask oneself, is the treatment turning out to be worse than the disease? And to the journey itself, I bow with gratitude. It has been imperfect, but it is mine. Thank you, ladies and gentlemen, for your patient hearing.